Well, hello, I'm Mary Beth Kingston, Chief Nursing Officer at Advocate Health, and I'm pleased to welcome you to the American Hospital Association's Hospitals Against Violence virtual convening on facility safety and security in healthcare. We thank you for being part of today's program, and a very special thank you to those who submitted questions for our distinguished panelists. You know, we know that safety and security of our workforce, our patients, and our visitors is critically important in providing the best quality care and also a healthy work environment. Hospitals Against Violence, or HAV, was established in 2016 and works to bring you leading practices and examples from the field. And facility safety and security is absolutely foundational to these efforts. We'll begin the program with a panel discussing proven safety and security strategies in healthcare, featuring the Joint Commission and the International Association for Healthcare, Security, and Safety. Next, we'll have a panel on innovative violence prevention strategies, featuring law enforcement experts, and they'll be exploring new models and improved partnerships. And our program concludes with an outstanding case study from two New York hospitals, New York Presbyterian and Northwell Health, as they share their perspectives from the view of a healthcare security leader. So let's begin today's program. It is my pleasure to introduce Kurt Barwis. Kurt is the president and CEO at Bristol Health in Connecticut, and is also a member of the Hospitals Against Violence Advisory Group and the American Hospital Association Board of Trustees. Kurt, I'll turn it over to you.
Thank you, Mary Beth. Thank you for that introduction, and thank you to the AHA for really putting this program together. This back on. We have an excellent group of expert panelists today, and I'd like to start by introducing Bonnie Michelman. Bonnie is the Vice President, Chief Security Officer of Mass General Brigham. Bonnie has extensive leadership and security management experience, and I would add that Bonnie was at Mass General on April 15th, 2013, playing a critical role in the organization's response to the Boston Marathon bombing. Bonnie has been a criminal justice instructor for 25 years at Northeastern University. Bonnie is extensively published on safety and security. Okay, that's better. Leadership and management. And then we also have from the Joint Commission, Tabitha Vueg. She's an associate director with the Joint Commission. Tabitha has transitioned from the provider side to the Joint Commission just about 10 years ago. She's an RN with over 30 years of nursing experience and is a certified change agent. I encourage participants to view both of their bios in the program. Bonnie, please get us started by discussing the key issues facing hospital systems today related to safety and security, strategies to meet the new Joint Commission standards, the key elements needed for a workplace violence program, regardless of an organization's size, rural, urban status, financial resources, etc. Bonnie?
Thank you, Kurt. Good afternoon, everyone. It's a pleasure to be here. This isn't an easy question, and this isn't an easy field to manage. I've been doing this a long time, and I've seen a lot of changes. As a former president of the International Association for Healthcare, Security, and Safety, and helping write some of the guidelines for healthcare security and violence, I think that we are at a pinnacle point in seeing vulnerabilities that we've never seen before, seeing the prevalence of violence that's massively exposed people to vulnerabilities that we have never even thought about. And the pandemic, frankly, has made it worse. First, I'll just talk for a moment about some of the trends that hospitals are seeing across the country, across North America. Certainly, we look at foreseeable versus unforeseeable events, and it's much easier to plan for foreseeable events, but there are always going to be unforeseeable events that occur in healthcare, unfortunately. So being aware of those, planning for those, drilling for those is so important. We've seen an increase in length of stay due to the inability of many states to have appropriate resources for the number of psychiatric patients that are in need. We've seen issues around undomiciled people that have affected healthcare and needing help from healthcare, needing shelter from healthcare. Currently, the migrant crisis has created some significant issues in hospitals around the country, in particular states. We've seen a lack of psychiatric resources that creates, again, that length of stay or that acuity of say psychiatric issues. We've seen an increase in opioid and alcohol addiction since the pandemic. We've seen an increase in hate crimes. Sadly, over the last few years, a huge increase in hate crimes in many areas. LGBTQ, anti-Semitism, which is massively exploding right now, and racial hate as well. There's a lot of compassion fatigue. There's a lot of fatigue from healthcare workers. We're seeing a lot of discriminative behavior by patients and visitors around people that they have biases against. We've seen a lot of geriatric population now who, through no fault of theirs, unintentional violence may be creating violence with Alzheimer's or other kinds of geriatric related issues, as well as people that may have head injuries or autism, or again, the non-intentional violence that still plagues our facilities. Our caregivers are scared. They're watching the news. They're looking at social media. Our people who work in ambulatory care facilities, which often doesn't have the same types of security as the motherships do, are concerned. And we're seeing specific and specialized concerns around populations that we didn't think about before. For example, people who now clinically work with transgender populations are being targeted, sadly, at some hospitals in some big ways by extremists that are against people who are working with transgender, particularly transgender youth. We're seeing people that are vastly against abortions, who are targeting clinicians who work in women's reproductive areas, whether or not they do abortions. We're seeing different kinds of research extremism for those healthcare organizations that do a lot of research, whether it be anti-vivisectionist research against animal research, whether it be AIDS research, whether it be any other kinds of research that people may have some aversion to. And then when we have a lot of conflict, as we are starting to see, and difficulties in our country, with a lot of differing responses to what's going on politically, that's bringing more protest groups. It's bringing more civil unrest. So all of those things are very tough. So let me get to some of the solutions. It's very important that we have a comprehensive workplace violence and conflict program. A lot of hospitals are very good about putting active shooter programs together, and they're not good at the other stuff. And the other stuff is what's most prevalent. Hospitals actually have the lowest amount of active shooters of any industry in the country. The largest amount of violence, but the smallest amount of active shootings. So we need to certainly empower and educate people on active shooters, but we need to educate people on workplace conflict and violence, and big stuff that's not always assault too. Verbal assaults, harassment, threats, bullying, intimidation, all of that. We need to have lots of departments involved in that, collaborative approaches. So there's many different people working on it. I always equate that this has to be a full hospital effort, just like hand hygiene is. We need to have patient care services, as well as police and security groups, as well as human resources groups involved in proactive things such as risk assessments and environmental design and data analysis and codes of conduct and threat assessments, and certain policies around visitor access controls, state-of-the-art security technology, certainly, harassment training and reporting. So lots of different kinds of things, and I've just given you a few examples. All hospitals should have a reactive program too, for things that unfortunately do happen. That should have emergent responses that people know about, that have been communicated, that people feel comfortable with. things about advanced notice if there's concerns about possibly patients coming in that may be a little concerning to some or visitors. Post-incident services, whether it be target hardening, whether it be some escort services for people that have been victimized, whether it be enhanced security systems, changing the design of someone's office, customized training. And most importantly, everyone needs to think about spending time with really, really good, robust de-escalation training so people feel empowered and educated. It is proven, I've done it in my own organization, that people that have gone through an in-person program, even for a few hours of a very good program, and there's several good programs out there, are victimized far less or not at all in any kind of healthcare violence and conflict than those who have not gone through that in-person program. So I can't stress enough about how important it is to do the training. People appreciate it. You don't want people leaving the workforce in any department because they don't feel safe. And this helps people to not only for retention purposes, but it helps people to feel like the organization cares about them and that they are equipped with the tools they need. You know, policies and procedures are great. State-of-the-art security technology is great, very good, competent, well-trained security personnel are critically important, but training really, really helps to create that culture to safeguard people along the way. So in closing, I would just say balancing patient care and safety along with keeping staff safe is paramount. A lot of times you'll have clinical people that are so committed that'll say, you know, you'll say to them after they've been assaulted, well, you saw that he was escalated or she was escalated and starting to get violent. Why did you approach without anyone? Well, I needed to get the blood test done. We have to teach people that they should not approach a patient if they have any misgivings at all without the appropriate help or backup until they know it's safe. Violence is rising in healthcare nationally. I think we've gotten far more sophisticated about hospitals investing heavily in good people and good credentials and good technology, but we have to keep that going. We know a lot of extremist groups are on the increase. People are joining them, unfortunately, and that can sometimes feather over to our healthcare environments. We know recruitment and retention is a challenge for so many groups in general in healthcare, and having good security can really help with that. So we have to get everybody involved, from physicians, which is very important, all the way down. We have to make sure people understand their options. We have to make sure we do emergency preparedness drills or exercises so people, you know, can know what to do in the event something sadly unforeseeable may occur. And I think when we do that, people feel a sense of relief that their organization cares and is on top of this. So I'd like to turn it back to Kurt and go on to Tabitha.
Thank you, Bonnie. That was really very excellent, and I appreciate all that. So, Tabitha, you know, please help us, you know, really kind of focus on the Joint Commission standards on facility management. Please share with us how the Joint Commission is assessing and surveying these standards. And if you could also help us by sharing data about the issues that hospitals and systems are struggling with during their surveys around these standards, I think we would very much appreciate that. Thank you, Tabitha.
Great. Thank you, Kurt. And so as Kurt mentioned, I'm here today to talk a little bit about the requirements that the Joint Commission's put into place to support organizations with their workplace violence prevention programs. I'm also going to talk about what some of the most common findings have been over the last 2 years, and also some of the things that I look for personally when I'm on survey. In addition to working in our central office, I also do go out a few times a year to survey hospitals. And then also where you can find some resources that'll help you meet the intent of these requirements. So the Joint Commission's workplace violence prevention requirements for hospitals and critical access hospitals went into effect January 1st of 2022. So we created these requirements again to support hospitals in implementing a workplace violence prevention program. Because we've all seen the statistics, as Bonnie talked about too, incidents of workplace violence against healthcare workers are staggering. And what's even scarier is that we all know that those statistics the workplace violence is completely underreported. So those statistics are really likely much, much higher than we think. So what we did is we created 3 new elements of performance and we revised 2 of our elements of performance. And I'm going to summarize them very quickly since there may be some organizations out there who have not been surveyed to them yet. So we have a new element of performance in our environment of care, chapter. It's EC 020101 EP 17. And this is that the hospital conducts an annual worksite analysis related to its workplace violence prevention program. In addition to completing that worksite analysis, the hospital also needs to take action to mitigate or resolve any of those workplace violence, safety, and security risks that were identified based on the analysis. In the environment of care chapter also, there is a standard, it's EC 411. There are 2 EPs under there. There's EP1 and EP6. And these are long-standing elements of performance that required hospitals to establish a process to monitor, report, and investigate security incidents as a whole. So what we did is we added incidents specific to workplace violence to those EPs, just so that they make sure they were included in that process of the monitoring and reporting. There is a new element of performance in our human resources chapter. It's HR 10503 EP 29. And this is that there's education and training at the time of hire, annually, and when there are changes to your workplace violence prevention program. And that EP also includes a list of topics that need to be included in that education and training. And the last new element of performance is in our leadership chapter. It's LD 030101 EP 9. And this is that your workplace violence prevention program is led by a designated individual and developed with multi-interdisciplinary team involvement that ensures that policies and procedures are in place. There's a process to report incidents. There's a process to follow up and support victims and witnesses, and that incidents are reported to the governing body. So since the implementation of these requirements in January of 2022, the most common finding we've had in all of our surveys has been in that EC chapter 020101 EP 17. And the findings for this, it's the worksite analysis. And the findings for that primarily were that there just wasn't an annual worksite analysis done, period. Or if it was, there was no evidence of what actions were taken to mitigate or resolve the risks that were identified. So that annual worksite analysis should be included in the list of documents that you provide to your life safety code surveyor. And so just remember that we're not just looking for that worksite analysis to be done, but we want to look and see what actions have you taken to either mitigate or resolve those safety and security risks based on your analysis. And so one of the most common questions we get is, what should be in the worksite analysis? And there really is no one size fits all answer to that, because no 2 hospitals are the same. Let alone these are also applicable to critical access hospitals who have far fewer resources. But all facilities are different. Even 2 right down the street from each other are very different, and no one has the same resources, whether that's people or money that's available to them. But one of the best worksite analyses that I've personally seen when I've gone on survey was super simple. It consisted of 3 different columns. So that first column was, these are the questions that we are asking ourselves in the areas that we're assessing. The second column was simply a yes or no. Have we evaluated this and did we identify a risk? And then that third column was just blank for notes and action steps that are needed to either mitigate or eliminate a risk that was found. But the cool thing about it, for as simple as it was very comprehensive. It started out even with a leadership assessment. They asked themselves, is there a culture of safety at this organization? And are our leaders committed to workplace violence prevention? Because if the answer to that is no, and you don't have leadership support, implementing a workplace violence prevention program is going to be nearly impossible. The other thing that really hit heavily was the education and training, and our staff, and it asked certain questions like, are our staff able to recognize precursor signals of violence? Have they been trained in de-escalation, in non-physical and physical intervention skills? And is this ingrained in our orientation? Do we make sure that everyone who comes into our organization is trained on this? And do we do this annually? And, also it's kind of a thing of, is it computer-based learning or is it a skills day? Because there are certain of these techniques you can't learn by taking a computer-based learning test. So another question they asked themselves is, have we clearly outlined expectations for our visitors and our patients? I know almost every hospital I've been into in the past year or so, they have signs everywhere saying verbal abuse, physical abuse, profanity, et cetera, is not tolerated. And so it's just really good to set that stage up front, it just helps level set with people. When they start to get a lot of control, you can kind of point to, hey, look, we're not tolerating this. And then, hopefully that kind of helps resolve. If not, you need to take further action. Another thing it really dug into, this worksite analysis dug into the high risk areas. They ask themselves, do they have secluded locations, unsecured doors? Are there blind spots in their security cameras? When and where do these incidents occur? Is there a pattern? Are 90% of our incidents happening at 2 a.m. on a Saturday morning in the emergency department? And also it really looked at, where are there locked or restricted areas? Do they have the ability to lock down a nursery? Do they have panic switches or alarms? They really dug into the policies that they had. So in addition to some of the policies that you would expect to see about training and reporting, it really, talked about, do we have criteria for behavior alerts? Of course, the restraint and seclusion application, at what point do you implement those? When do we release information to law enforcement? And also, how do you manage terminated or even disciplined employees? So the next most commonly scored element of performance is the HR 010503 EP29, which is the one about training and education. And most of those findings were that there was no evidence at all that anyone was being educated across the board. If there was education, we found that sometimes there were key groups of individuals that never received training, like leadership, for example, or licensed practitioners. Or the last part of that too that we would find is that there were just key pieces of the education that weren't provided. How to report, or what is the role and responsibility of different staff members when there is an incident. And so when I'm out on survey, I usually like to ask the staff, tell me about the training that you received. I learned very quickly, you don't say, so do you receive training in workplace violence? Because of course everyone just nods yes. But I ask them to tell me about that education. What does it look like? Is it all CBL, or do you have skills days? I really like to hit that, particularly when I'm in the emergency department, the ICU, and L&D, because in my history and my experience, those are the places where emotions run high. And I'll usually ask them, so what do you do in a particular situation? What if there is an overhead notification that there's an armed intruder? Or if you have an angry patient or a family member? Or what happens if you're on labor and delivery and you have an estranged partner who's trying to gain access to the unit or to a room? And what I'm doing with that is I'm actually just trying to assess if workplace violence education is a check the box for this organization, or if the staff is truly prepared for incidents. The third most commonly scored EP that we see is that leadership one. So the LD 030101 EP9. And this is that the prevention program is led by a designated individual with input from the multidisciplinary team. Many of the findings there were due to lack of PMPs being in place. There wasn't a process to report incidents, or there also wasn't a process to follow up or support the victims and the witnesses. And so another thing that I like to do when I'm on survey too is I encourage organizations to use plain language for their codes. Because depending on where I've been, codes can mean different things. Code gray can be there's a storm rolling in, or there's an agitated or combative patient or family member. And again, most people know code blue. Most of us, anybody that watches a television show with a hospital knows code blue. But what happens if that code is lesser known to the public? If family members don't know what a particular code means, they may come wandering out of the room to ask, hey, what's going on? And if it's an armed intruder, the last thing you want is for that to happen. And so we understand that, thinking about how to meet all these requirements can be overwhelming. And Bonnie provided you with a lot of great information earlier. But also when we were developing these requirements, we also created a compendium of resources to help organizations comply with the workplace violence standards that we put out. And those can be found on the Joint Commission website. You can find them on the website. It's kind of our main website, jointcommission.org. At the top panel, they'll see an Our Priorities. When you click on that Our Priorities, a panel will open up on the left-hand side, and workplace violence is one of those. It'll take you to a landing page that will take you right to these compendiums. And I can also, when I'm done, I can paste that link into the chat also. We learned a great deal while we developed this compendium, but what stood out most is just the overwhelming support that we got from organizations who were willing to share their resources. It was just truly a testament to how important it is to find these resources and to share them. The resources were compiled from key stakeholders across the country, national organizations, federal state agencies, professional organizations, and relevant academic institutions, peer-reviewed publications, and also some private entities. Everything that we are providing on that compendium is available for free to the public, and it's intended to provide a range of opportunities. Because like we said, there is no one size fits all. Nobody's organization is the same as anyone else's. And so just very quickly, the compendium itself, oh, thank you. And I saw somebody put it in the chat for me already. The compendium, when you click on it, there's a list of all the organizations and entities that provided resources for us. And along with that, there's a check marks. Is this going to help you with your worksite analysis, with policies and procedures, or with education? If you really just don't know where to start, if you go to the end of that compendium, we have an index by issue. So if you know, I have no idea what to do with a worksite analysis, I don't even know where to start. If you go there, there's a whole section with worksite analysis, and it'll tell you who has information for you to do the worksite analysis. And when you click on that, it'll take you up and you can access the resources that way. In terms of next steps, very quickly, I know Bonnie talked about, sometimes we have these other areas that are very unprepared. So we are actually launching workplace violence prevention requirements for behavioral health care and human services for those customers in July of 2024. There will be a prospectus article coming out shortly to announce that. And then our plan is to start to roll that out to our other programs too, like home care, nursing care centers, and ambulatory. And so with that, I would like to thank the American Hospital Association for including the Joint Commission in the panel today.
Tabitha, thank you. Thank you very much. That was incredible. And I have to say, I really appreciate the Joint Commission in helping us lead through, as Bonnie described, this is an incredibly changing time. It seems like just about every other day I pick up a paper and hear of a new incidence of mass violence and impact on healthcare organization. I know in Connecticut, we collect the data, and every day there's 5 assaults on a healthcare worker every single day in the state of Connecticut. So, and I'm sure that other states are very similar. In kind of, reflecting on the things that Bonnie and you said, I really I appreciate the awareness that Bonnie really laid out, and then the solutions and kind of really the diversity in all the issues that are impacting us. But most importantly, what I think I take away is this call to action. We really have to do the best job we can to protect our workforce. And I use this example all the time. We have this tremendous shortage, and all one has to do is be assaulted at work and go home to their spouse and describe what happened to them that day. And in many cases, the spouse will say, "That's it. You need to change your career. You need to do something different." The imperative, the call to action is so strong for us to really engage. I personally find listening tours, I do town hall meetings, and that's the leading question that I ask. You mentioned, maternity and some of the other areas. Do you feel safe? And often it's simple solutions, as you described, Tabitha, that can make all the difference. And going back to what Bonnie said, what's most important is your team, your staff, your visitors want to know that you're paying attention, you're aware, and you're actually working to really resolve and then create a much safer environment for everyone. So, and I do agree, thinking about the size of organizations, the limits on resources. We literally used an outside large organization security team to come in and help us with our assessment, help us with placing cameras. Often you find resources that you don't realize you have, experts in your community, and it's a way to solve problems. So thank you both very much, Bonnie, Tabitha. This was really absolutely enlightening and wonderful. So I'm going to move on and briefly introduce the next panelist, person who's going to lead that, Tori Ardabell. Tony is the Chief Clinical Operations person for ANOVA. She's leading all clinical sites of care, including 10 service lines. Tony, handing off to you. Thank you very much.
Thank you, Kurt. I'm happy to be here this afternoon with 2 great panelists, and it looks like a large group of participants. Workforce violence is near and dear to my heart. As Kurt said earlier, I believe it's absolutely our job to keep our team members safe. But let me get right into introducing our panelists. First, I want to introduce Dr. Carrie Gibson, and then John Riggi. Dr. Carrie Gibson has been a special agent with the Federal Bureau of Investigation for 17 years and currently serves as the unit chief for the FBI's Behavioral Analysis Unit 12. Behavioral Threat Assessment, a national level multi-agency, multidisciplinary task force focused on the prevention of terrorism and targeted violence. Prior to the FBI, Dr. Gibson was and continues to be a licensed clinical psychologist, formerly working as an officer in the United States Air Force. John Riggi is AHA's first national advisor for cybersecurity and risk. He is a 30-year, highly decorated veteran of the FBI, where he served most notably as a representative to the White House, Cyber Response Group, and a senior representative to the CIA. In John's AHA role, he serves as a trusted advisor to the leadership of America's hospitals and health systems. I'm honored to have the opportunity to join Carrie and John today in this panel. Let's start with a question for Dr. Gibson. I'd like to ask you to share more about the FBI's Behavioral Analysis Unit, how the FBI is committed to working with healthcare to improve the identification and response to targeted violence, and describe how healthcare field is implementing threat assessment and threat management teams.
Thank you so much, Tony. I'm very happy to be here. So as you stated, I'm the unit chief for the Behavioral Analysis Unit, and one of our key missions is to prevent acts of targeted violence and terrorism. We've been active in that space for years, being very proactive in prevention. But in 2018, we decided to be a little bit more forward-leaning as the acts of targeted violence started to increase, and we started to work within all of our field offices, the FBI field offices, to be more forward-leaning in not only how to identify, assess, and manage threats to our community, but also to set up local infrastructure to help deal with mitigating those threats in a proactive way. From a law enforcement perspective, there's always been, I think, some stereotypes that feel like we can only use law enforcement solutions. And one thing that we've found in this threat assessment space and in this prevention space is that there's other tools that can be used along with those. And so we definitely are working at this from more of a community approach and recognizing that there are sometimes we need law enforcement options, but there's a lot of times where it doesn't even meet the threshold for law enforcement involvement as far as an actual chargeable offense. And so what can we do proactively when we don't have that? And that's that threat assessment, threat management. So from our standpoint in this preventative space, first we've worked with law enforcement officers to help educate on how to identify, assess, and manage. We've branched out to schools, we've branched out to mental health practitioners, and now we're branching out to the actual medical communities, the healthcare systems that are out there. Because what we're seeing is this is a community problem. And so if all of us can be on the same page with how to identify, assess, and manage, then we can help keep our communities safe. And so from the FBI's perspective, we are currently working with the American Hospital Association to be working more proactively with the healthcare systems out there and really connecting our FBI resources to those hospitals. And what we're seeing is that hospitals already are in that prevention space being proactive, and they have threat assessment management teams. And so we're working to integrate and to help improve and again share our research on what do we know about preventing these acts of targeted violence. In the FBI, we're fortunate to be a resource, and we have a lot of resources that traditionally have been given to law enforcement officers, and we want to be able to share them with the healthcare system. So thank you, Tony.
Could you give us a little more information on how smaller hospitals or critical access hospitals are implementing this type of work?
Yes, it's a challenge, obviously, for smaller communities and limited resources. And so we really look at how can we do more with what we have and take our systems that are already set up, that are already working together, and how can we, add to it. And so what we find a lot of times when we talk about threat assessment management teams, people will talk about we don't have the resources, we don't have the people, but then we fold back their processes, we will find where they actually already are doing a lot of the similar concepts, but they're not fully doing that threat assessment piece. So we just have to add to it. And so, for example, the big thing about threat assessment management is it's a multidisciplinary team that's coming together. You're working as a team to talk about problems and how to be proactive. And so there's many times you'll find we have a monthly meeting where we come together and we talk about high risk, you name it. This could easily be turned into a high risk concern where we can talk about what are we doing, what are we seeing, how are we being proactive, how are we mitigating that. And so we've just found that when we look at the areas that have limited resources, we're just really trying to look at what they have and what can be used in a similar fashion, and then also help them rely on or find resources in larger communities that are able to share, right? So they don't have to recreate the wheel and make it more efficient for themselves.
Thank you. John, would you provide your insight from the field as you work with healthcare leaders across the country? What are some of the lessons learned as it relates to cyber attacks?
Well, thank you, Tony. Great to be here. And folks are probably wondering, why is the cyber guy on this webinar here? And actually, there's a good reason. One, as we worked very closely with the FBI for many years to help understand the threats that are facing us as a field. And my last role at the FBI, full transparency, was to work with the private sector because we understood that against that particular risk, the FBI, the federal government, could not counter that threat on its own, just like with counterterrorism. We understood we had to work and leverage the expertise of the private sector and their perspective. So taking that on, and then really here at the AHA, we approach the cyber issue, but as a threat to hospitals, but also we look at all potential threats to hospital, including violence. And then at that point, we understood that, boy, the model we're using to work so effectively with the FBI on cyber threats, we think we can transfer that over to the violence issue, which is plaguing our hospitals. So the FBI is being as proactive and forward-leaning as they are to work with the nation's hospitals. They immediately jumped in. Dr. Gibson and her unit, behavioral analysis unit, offered resources and lessons that they could share. And they immediately realized that they really do need the perspective and expertise and resources from the hospitals to understand this community violence problem. So I heard Dr. Gibson mention several times this is a community issue, and absolutely agreed. This is really, I think, one of the finest examples of national community policing in the best sense, not for law enforcement and prosecution, but for prevention of violence, prevention of crime and violence, how the FBI can work together with hospitals, again, share those lessons learned. And as in cyber, we have learned that we are well beyond the cliche, know your local FBI. Yes, you must know your local FBI, but we need to work together in a trusted framework to exchange information, which is in compliance with federal law, patient privacy regulations, and we're learning how to do that effectively to help identify potential patients, staff that may be at risk of violence or may be contributing to that risk of violence, and how do we mitigate it and prevent violence and crime before it manifests itself in a very dangerous way. So I always say to folks, you know, part of my role here is hopefully to be that trusted broker between the nation's hospitals and the FBI and the federal government at large to help dispel the myths of working with the FBI. They're not these mysterious folks in dark trench coats that, you know, will only show up in a black Suburban and maybe Ray jackets. They live in our communities. They're our friends and neighbors. They depend on hospitals, just as we depend on hospitals, to be available and safe. So they're more than eager to work with us to help settle on this common national problem, whether it's a physical risk in terms of violence on our grounds or premises, or the virtual threats that we face every day, the cyber attacks, which ultimately do end up manifesting themselves with physical impact. Of course, the most concerning cyber threats we face every day are these highly disruptive ransomware attacks, which target hospitals. And folks, let's make it clear. These foreign-based, primarily Russian-speaking bad guys target hospitals because they know when they shut down our medical technology, lives are threatened. Patient lives are threatened. But these attacks are not just an attack on the patients within the hospital. They are an attack on our entire community. The reason is that our entire community depends upon the availability of that emergency department for, God forbid, should someone need that emergency department for a stroke or trauma or a heart attack situation. So as we work closely with the FBI to exchange threat information, develop strategies, how do we help counter that threat, help inform the government's strategy, both on defense and offense. Again, we those bridges that were in place, those good, strong relationships, we realized we could leverage this for the Hospitals Against Violence program as well. And again, having those trusted relationships, being respectful of patient privacy concerns, and not doing anything that could be misperceived as a profiling type issue. It's so sensitive these days. We want to make it absolutely clear that when we talk about these threat assessment programs, again, it's assessing and it's behavioral based. Of course, that's why Dr. Gibson is here to lend her expertise. That is not demographic based, it is behavioral based. And again, so the success we've had on a number of issues, risk issues, we're hoping to transfer those lessons, and developing these national models, I think, will ultimately help benefit all the hospitals in the nation, implemented at the local level, national model, but implemented at the local level, and then again, continue to build our relationship in a whole of nation approach to a risk issue. So let me stop there and back to you, Tony.
Thank you, John. I have to say, maybe it's living in Northern Virginia, but we find the FBI very helpful. And they're always there when we call them. Our previous leader for security for the system was a retired FBI individual. And I used to think it was his contacts that made it so easy. But you guys do great work, and we just appreciate all you do. Dr. Gibson, I'd like to come back to you for a minute. And, you know, one of the things that we heard, and one of the questions that was asked, sent in early, is as we create workplace violence programs and try to increase safety, how do we make sure they're equitable and they're not perhaps stereotyping or unfair to certain cultures?
You know, with everything happening these days, it's a very complex picture. And I think that if you focus on what the key goals are, is to prevent violence and then go from there. And so you have two types of violence that can happen in the hospital setting, right? You have that regular kind of emotional violence or affective violence that happens in reaction to you know, a situation or contact, an agitated patient. That's obviously happening at a higher frequency. That's more of a normal that the hospitals are seeing. And then you have the other side of it, the predatory violence. It's more targeted violence, maybe a stalker that's fixated on a doctor or a patient. And you have to then start to look at your workplace violence prevention program to include all of the violence and be very clear in how you define that. And so you have the violence that comes from those situations, but you're also going to have the insider threat that could happen with potentially violence of your own people on your own people, and then violence coming from the outside onto your people. And so culturally, it's going to be complicated because you're going to have all aspects to consider, but that's why it's so important that you focus on clear definitions and clear process and clear action that can be done. And if you focus on that, it will take some of those cultural components out of it, because at the end of the day, we don't want to stereotype in any specific you know, category or you know, make a misstep based off of more of an emotional response or a current event response that's happening. And that's why those definitions are so important. The other thing I will tell you is that in that process of workplace violence, if we're going to get it right, we have to pay attention to imminence, and we need to make sure we have a plan of action for imminence. You know, I've seen some workplace violence processes and policy not be able to kind of pull that imminence part out and react according to what those behaviors are showing. And so again, just something to consider when we're doing, when you're looking at your workplace violence processes. And then again, you're going to not only have the key times that are going to impact that, but also your own dynamics for your own hospital and the limited resources or extra resources that you may have.
Thank you. John, I just saw a message in the chat, and so you are not aware that I was going to ask you this question. So, when we talk about workplace violence definitions, should there be national definitions across healthcare, or is it okay for everybody to have their own definitions?
That's an interesting question. I'll do my best to answer that, not being my full area of expertise, but I'll rely on my, lessons learned on cyber guidance and guidance on just general risk issues. I think there can be a national framework, perhaps, just as we have national standards for cyber crime prevention, but there must be local input as well. But I think to operate at least within a general framework, so we can arrive at least some understanding of standard definitions, I think would be helpful. State law must be taken into consideration as well, because ultimately, violent acts are a state violation primarily. That would be handled at the state level. So we need to understand what the state definitions are, legal definitions are as well. But I think, again, national model, national framework to provide guidance that then could be locally tuned based on local issues, local and state laws as well.
One thing that I've learned in the past few years is each local jurisdiction is different.
Right.
Depending on the resources the jurisdiction has to give to a hospital. Fairfax County, great resources. Perhaps the city of Alexandria, maybe a little less resources. And so, and each jurisdiction might have some of their own definitions and things as well. So really, I think both of you have mentioned earlier how important it is to work with the FBI and organizations outside of healthcare in order to keep healthcare safe. And I think that's really important. Dr. Gibson, what didn't I ask you that you want people to know today?
One thing that as I've been starting to work more with hospitals, that is one of the reasons why I wanted to be a part of this initiative is, with my background as a psychologist and as a law enforcement officer, I see many times where there's really very, very strong boundaries between the two fields and silos, and where a lot of individuals feel like we can't share or talk to each other because of the different rules that we have to abide by. And I'm not saying that we just shouldn't, follow those rules and follow HIPAA or anything like that. But what I do know, when it comes to community safety, we have the ability to be more proactive and talk openly about how to keep people safe. And I think that a lot of times there's barriers that are unnecessarily put up that prevent that from happening. And when law enforcement is finally called, it's much farther down the path and much harder to kind of have a non-law enforcement solution, because behaviors have escalated to such a point that it is problematic. And so I really want everyone to know that law enforcement is being very proactive in the prevention space. They don't just have to arrest people. We're out there educating and sharing information with law enforcement all the time to recognize the importance of this and helping bring down barriers. And the same with the medical community. There is the ability for us to be involved in talking sooner than we are right now, and still maintain the privacy that we have to according to the different laws. And so that's one thing that I think as we start to partner, it's important to know that, to try to bring down those silos. After every one of these attacks that we go through and we do a post-attack analysis, one of the key things we find is that not everybody had all the pieces to the puzzle. Not everybody had the full complete risk picture, because certain people had certain pieces and they weren't communicating and sharing it. And so that's a real key part of this. I think we all have a responsibility to try to figure out how can we work better together. And what that means, our community is safer, and that, we are safer within that community. So that's important. And then I'll just add really quickly that, again, from the side of research, we are at the FBI's BAU are very proactive in this space, and knowing the key factors of why people go on to commit acts of targeted violence. And so one key thing that we know is there's a thin line between suicide and homicide. And we have to really look at suicide prevention as a way to prevent homicides. There's key things like that we can share, and that we are going to continue to share with the medical community, that will inform your assessments of your patients that come through your doors. Thank you, Tony.
I'm going to ask you the next question also, Dr. Gibson. which is around de-escalation. Somebody asked a question in the chat about, could we drill down more on escalation? And before I ask you to respond to that, I do want to say that Inova made de-escalation training mandatory this past year. And then we did town halls just on workforce violence. And it seemed very effective. And I noticed earlier somebody asked if security officers could be trained more to help in de-escalations. And again, at Inova, all of our security officers do have 3 levels of de-escalation training and can be asked by the nurse to intervene at any time with de-escalation. And it's very, it makes it a team between the nurse and the security officer, which makes a much stronger team. And so, Dr. Gibson, what are your thoughts around how we can really drill down more on de-escalation?
I mean, that's a necessary tool to have in our toolbox as both law enforcement officers as well as members of our medical community. And really, everybody should have it. And that's one of the things that I think is important. If we all share in that space and we have that, then we have that common knowledge. And then we're all together in the team, just like you said, everybody knows kind of what we're all looking for. And then we're able to work together and use that same language. I feel like if we have a tool like that and we don't share it with everybody that has that ability to have contact with people, we're really setting ourselves up for some type of event to escalate. It's just how it goes, right? That you may have 95 people that's trained in de-escalation, and the one person, you know, who didn't get it that day is going to encounter that patient who needed it the most. And so again, if we can saturate that and get that skill out there and that knowledge to everybody in our workforce, it's important. It's not only important at work, it's at home as well, that it's a good resource for people. And I think that's an important piece. And we encourage that in our law enforcement communities as well.
Thank you. So John, last question for the panel. What would you like to tell the group that I haven't asked you about today?
Well, I think, you know, Dr. Gibson provided such a great summary. I just want to echo some of her sentiments and statements. Beyond just knowing your local FBI, sit down, have a meeting with them. We hope to put out a national framework or guidance on this issue within the first half of 2024. Start developing a real plan and initiative on the issues we talk about, on threat assessment, threat management. How can we transfer these lessons locally? And again, working together. One part I will talk a little bit, it's a blend of cyber and risk reduction, violence risk reduction in hospitals, is that many organizations do in fact bring in lots of technology, cameras, door access controls. Diego from New York Presbyterian and I have had many conversations about not only the security technology, but the security of the security technology. A lot of that is internet connected. So technology can be an enabler in these situations for risk violence reduction on hospitals. We also want to make sure they're cyber safe. So I do have to give that a plug to make sure that any of the technology we use for violence prevention mitigation, if it's network or internet connected, it may pose a risk for a different type of threat, that virtual threat. But besides that, again, I want to commend the FBI once again for leaning in, being tremendous partners with us to help protect hospitals, to defend our communities and defend the nation, and really appreciate everything they do every day. Even in this very challenging environment for them, they put their heads down, they do the job. And thank you all for this opportunity to chat today with you.
So thank you, Dr. Gibson. Thank you, John. It's been a pleasure to be on this panel with 2 experts that I'm sure helped give new information to the audience today. So I appreciate that. Next, I want to introduce Diego Rodriguez. Diego serves as the Vice President of Security for New York Presbyterian, and he was just referred to by John. Diego is a first-generation Queens native and formerly oversaw the FBI's New York field office, which is the Bureau's largest office. So Diego, it's all yours.
Thank you, Tony, and good afternoon, everyone. It's great to be here and be part of so many experts on the different panels. With the rise of workplace violence, it's important that we do get a perspective from security leaders in healthcare. So I'm really proud and privileged to introduce our next speaker. And, you know, something that is important for us to just kind of go over it before I do that is, you know, regardless of the industry you work in, you know, chief security officers, they work together closely. And in particular here in New York, we're very lucky. We have some really good ones, and we collaborate quite often. And, you know, Scott Strauss is one of those partners that I'm fortunate to get to work with and share the good and the bad. And, you know, we go over things and then discuss how we can do better and maybe secure our hospitals in the best fashion. Scott is a vice president of the corporate president of Northwell Health in New York, the largest private employer and healthcare provider with 21 hospitals and approximately 900 care centers servicing an area of over 12 million people here in New York. His responsibilities include the supervision of all investigations and the coordination of local, state, and federal law enforcement entities with the health system. He's also charged with developing, organizing, planning, and coordinating and enforcing all the security policies and programs within the system. Scott is a retired detective from the Emergency Services Unit here, an elite unit in New York City, in the New York City Police Department. He's received numerous awards for his bravery and service, including the NYPD's Medal for Valor. And on September 11th, Scott was part of a team that risked their lives to rescue two New Jersey Port Authority police officers trapped in the rubble of the World Trade Center. Scott received the NYPD's highest award, the Medal of Honor, for his actions that day. In addition to his career with Northwell Health, Scott is also an active person in his community, completing 4 terms as mayor of the village of Mineola, a position he held through 2011. And he's also a 42-year member of the Mineola Volunteer Fire Department, where he has been a line officer and rose up as the department's chief. And lastly, he's also a fellow Eagle Scout, which is fantastic to hear, Scott, from Troop 45 in Mineola, where he grew up. So welcome, Scott. It's great to have you here. And before we get into and ask you the first question, you know, we've heard from our previous panel experts regarding their perspectives on workplace violence and how it impacts their respective areas. You know, I believe from a physical security standpoint, it's important to discuss how, regardless of the size of our hospitals, you know, some of us work in urban areas and some in more rural areas, how we all face the same challenge of workplace violence. And in many ways, if you think about it, workplace violence is non-discriminatory, right? It can show up on our doorstep and when you least expect it. So, Scott, if you were to advise the audience here, what security measures can hospitals take, regardless of their size, to address workplace violence, and as a result of that, benefit from the reduction of workplace violence?
Great. Thank you very much, Diego, and I appreciate the other panelists. All great information. And it's kind of reiterating what most of our panelists have already said. Number one thing is training. I know that costs, as Diego mentioned, is always a factor, certainly for the smaller hospitals. But if you could reach out to some of the companies, or in Northwell, we not only do it because of regulatory issues and concerns. We have an outside company come in and teach us in de-escalation, physical and verbal de-escalation, but we created our own training program for that as well. Training, it does initially cost some is a financial impact, but if you take a trainer course, then you can minimize that financial impact, and you can just train your own people and continually on an annual basis. Training is incredibly important, and we live by that here at Northwell. As I mentioned, we've created our own verbal de-escalation training class that we give annually to all of our employees. We're trying to make it a required topic for all of our employees to take, and we have 86,000 employees. It's certainly a Herculean task, and we manage it the best we can. Some of the other training topics that we have, in addition to the verbal and the physical escalation training, is obviously the active shooter training. We've created our own as well. There's been many discussions on run, hide, fight, and what do we do for clinicians who do not want to run, who can't run, their patients can't run. So we've all, embraced the concept of secure, preserve, and fight. Secure your patients, secure you, preserve their life, preserve yours, and then fight if you need to at the end of it. As well as bleeding control. Bleeding control is important, not only inside a hospital or a healthcare facility. Heaven forbid we have an act of mass violence, whether it's active shooter or slashings, but it also helps, that training helps you at home. It helps you at the workplace. How many times have people been driven past a car accident, and what's the leading cause of death in situations like this is lack of blood, bleeding loss. So if we can control bleeding right away, and not everybody in healthcare is a clinician, and not everybody in healthcare has that training. But if our back end office people and our EVS workers, everybody gets the bleeding control training, will certainly save lives. God forbid we run across that situation. Some of the other things that. Go ahead, Diego.
No, I was going to say we've seen that as well. We say stop the bleed training, and I know a lot of law enforcement entities are now relying on that and trying to drop some of those stop the bleed kits sometimes for members of the staff, to provide that quick care and make that area secure, where if there are fatalities or people injured, they can secure that area so that they can continue to clear the hospital. So that's a big deal now, I know, within law enforcement, going into different locations when there is an active shooter. You mentioned the trainings and stuff. What kind of trainings do you guys do? Tabletop trainings, and and when you do those tabletop trainings, do you include law enforcement?
We do. Excuse me. We do several different types of trainings. When we do tabletop trainings, we do include our law enforcement partners, and building those relationships is tremendous. We encourage here at Northwell our law enforcement partners to actually hang out in the hospitals, hang out in our facilities. Some of our hospitals have created rooms. It doesn't have to be elaborate. Just a small room for our police officers to come in, do paperwork, write their reports, maybe have a cup of coffee, maybe go to the bathroom in a clean place. And we encourage them to hang out in our facility. If they are familiar with our facility, they're familiar with our operation, they're not seeing us for the first time when an incident arises and they're racing in the door, and they become more familiar with the complex. So we encourage strongly, and that's another thing that doesn't cost a lot of money for some of the smaller hospitals, is the relationship building with law enforcement. Some of the other types of training drills that we do are something very simple. One of the better ones has been have a person walk around our facility with a bright orange shirt on, and have our camera people, our security team, try to locate that person. They get a phone call from the nursing station. Okay, we just saw him here on 3 Cone. And then our camera person is trying to pull up those cameras. And I can tell you that we've had our best people on the cameras, and an incredibly low stress situation, right? They're just looking for a person in a bright colored t-shirt. It's not easy to do, right? There's a lot of dead spots, so to speak. There's a lot of areas that, okay, where are they going, up or down? They go making a left or making a right? Because not every place is captured by cameras. And that's relevant because, heaven forbid, we need to find somebody in one of our facilities and law enforcement is standing right next to us. The stress is on, the pressure's on, and they want to locate that person as quickly as possible. One of the other things we do is what happens after the situation. For a shooting, for example, the shooting happened. It happened in pick a place in your facility. What do you do now? It's a crime scene. Is it locked down? How do you continue to feed patients? How to continue to treat your patients? Did the dietary team run when in accordance with the run, hide, and fight? And are they coming back? They might be too distraught to come back. So how do you continue to feed your patients? Do you need resources from another hospital, maybe outside of your organization? How do you get staff in to replace those who are injured? How do you get staff in to replace those who don't want to work, who are traumatized? So it doesn't always have to include law enforcement, doesn't always have to include an active shooter. It should include, though, the aftermath, because we're all going to have to deal with that.
Yeah, those are excellent points, Scott. And, I noticed some folks have previously asked about the training, and I know it was alluded to already, some of the de-escalation. And what kind of training we offer our officers, to handle some of this violence or aggressive behavior. I know at New York Presbyterian, we provide management of aggressive behavior training to our officers, and now also de-escalation training, which is mandatory. And it's been embraced so much, not only by our officers, but it's been seen by clinical staff. We are offering it to them as well. Along those lines, what kind of training do you provide the officers to help them with dealing with some of this violence?
Our officers, and we started an armed program here about 6 years ago. That's been hugely successful. I'm going to jinx myself by saying that. But it's been hugely successful, and we have given our armed officers as well as unarmed officers the same level of training, obviously not in firearms, but certainly in de-escalation. We have verbal, as you mentioned, de-escalation, physical de-escalation, the MOAB training, there's CPI, there's PMCS, there's many, many companies out there, all of them very good. And we've created our own internal verbal de-escalation training. Past that, we have provided all of our security officers, whether they're armed or unarmed, with pepper gel. We don't use pepper spray, we use pepper gel because we don't want it aerosolized going into the HVAC system and spreading throughout the hospital or the facility. And that alone, we have seen a decrease in workers' compensation cases, which goes back to the finance issue. So less time out, less injuries, of course, is the main thing, and less financial impact on the institution. Pepper gel has worked many times, all of them successfully within Northwell. So we give them that training as well. Now, going back to the law enforcement partner portion of this, we have our local law enforcement officers, whether it's New York City or Nassau County or Suffolk County or Westchester County, police officers train with our teams on their special operations teams, have actually seen the level of professionalism our security teams have, and they've asked us to include them, our own teams, in their trainings in managing an active shooter scenario. And not only our armed teams, but our unarmed teams as well, because everybody plays a role. We can't expect our security officers to act appropriately in an active violence situation if we don't give them the proper training and give them goals and objectives of what they need to be. Otherwise, they'll be running faster than everybody else out the door. So it's important to give that training out.
What you just described and what you've been describing about the interaction with law enforcement, it really boils down to investment, right? Investment in them, like you said, even the small things, having them stop by, in the winter months, grab a cup of coffee, stay warm, developing those relationships. I think John Rizzi mentioned earlier, demystifying not only FBI, but law enforcement as a whole. As a former retired FBI agent, I used to always have to do that outside because, people had their, perspective of what they are and what they do. And so the more you kind of get them used to, the staff get them used to that, I think is very important, especially in light of, what's going on with some of the behavioral patients that are walking into our hospitals and how often we may be calling law enforcement to assist us. One thing that you mentioned, and I think it's important to mention, hospitals come in all sizes and shapes. And if you're in a rural area, you may not have the NYPD, a big department there. You might have to deal with several departments or local departments of state police. Please do invest in those relationships. Invite them to your tabletop trainings. Invite them for a coffee. have them meet your president, again, demystify them to the staff so that they're not feeling anxious when they see them come into your hospitals. Scott, any last words before I turn this back over to Mary Ann?
No, I think you said it right, Diego, and you've been a phenomenal partner in all of this with Northwell. As John mentioned, we have you've had weapon detection systems in place in your facilities for many more years than we've had them, and we reached out to you and you kind of guided us through that. But folks, reach out to your counterparts, not maybe necessarily in your area, but other hospitals. Reach out. We all don't have the same. We don't all have the same answers, but we all have the same problems, and we can build upon those answers, and we can build upon those problems, and make them hopefully make our hospital a whole lot safer. But the relationships with law enforcement are tremendous. You want to encourage those, as Diego said, and train. Make it muscle memory.
Right.
Two key parts.
No, I 100% agree, and truly appreciate you participating today and bringing your subject matter expertise to this panel, Scott, and look forward to continuing to work with you here in New York. With that, I'd like to turn it back over to Mary Ann.
Thanks, Diego. Thanks, guys, for putting this all together. Greatly appreciate it.
Well, I just wanted to say thank you to everyone. I'm Mary Ann Fuchs, and I serve as the Chief Nurse Executive for Centra Health, but I'm a member of the Hospitals Against Violence team. And, I'd start by saying, Kurt said this when he started, what is our call to action? And, I want to say thank you to Kurt and Tony and Diego for serving as our moderators today, and all of our participants. But I think this was an incredible session with incredible participation from across the country. And so as we continue to identify, assess, and manage those violence events. And I think, Bonnie drove home for us what the challenges and how our environment is continuing to change and become more violent. And, just talking in general about some of those key strategies, Tabitha from the Joint Commission really providing us a structure to support our organizations for workplace violence programs, and the importance of that annual assessment process to understand where an organization is, and then develop actions to mitigate or resolve issues, and just the ongoing need and support for monitoring, reporting, and educating staff, and having that available compendium of resources that's available for free for everyone. And the same thing as it relates to our American Hospital Association, the resources that are out there in addition. Dr. Gibson, and understanding the community approach to threat assessment and the need for that proactive preventative approach, engaging schools, mental health organizations, healthcare organizations to identify and to assess and to manage the opportunities to address violence. And John, working with the private sector in just that whole concept of national community policing to prevent violence, and identifying, working with hospitals and the FBI, healthcare organizations, to identify patients, staff, visitors, et cetera, that might be at risk, and what's going on in the community, and how can we work together to help to mitigate some of the challenges and to prevent violence becomes even more important. And what I heard John say is that we may have a national framework available coming to us in 2024 around threat assessment. So I'm excited to hear more about that as we move forward. And I think Diego and Scott, they just drove home and reinforced all the strategies that we need to really be focusing on, with the high emphasis on training, that verbal and physical de-escalation and active shooter drills, and really the importance importance of building relationships with local law enforcement, no matter what your size, working together, partnering together, planning together, understanding how working together can really be extremely important in managing these types of situations. And then I think the other takeaway there is, if you do have an event, what happens afterwards, and how do you provide continuity of care within your organizations and provide that need for staff and to be able to continue that. I think today, we are bound by continued challenges within our communities. We know that workplace violence and community violence are going to continue to be a challenge for us. The more we can be proactive, the more that we can learn from one another today and in the future, I think the better off we're going to be. And so I really want to thank everyone on behalf of the American Hospital Association for their participation today. And I would just say there's some key takeaways. We'd love for you to complete our survey and check out. You can see that link here. But thank you for attending today, and we look forward to work in our continued work in the future. So thank you.